Well, hi, everyone. Thank you so much for being here. We're going to go ahead and get started, even though it's a small group this morning, but we think some more people will be trickling in. I'm Liza Greenberg. I'm a quality consultant with the Visiting Nurse Associations of America, and I work on our Blueprint for Excellence Best Practices website. So for those of you who haven't visited that website, there's a lot of great information on it around star ratings, best practice activity. We just added new Impact Act information, and then there's quite a bit of chronic care management information. So an excellent resource for members and non-members. So I'm here to introduce our session, Kenosha VNA's collaboration with the county sheriff. The session is presented jointly by VNA and the Alliance for Home Health Quality and Innovation. The session is being recorded. It's a continuing education activity approved for 1 contact hour by the Maryland Nurses Association and accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. If you want to receive a certificate of completion, you need to attend the entire session and complete the evaluation. The evaluation survey is in the conference app, and if you have any trouble downloading the app or finding the survey within the app, let me know and I'm happy to help you find it. Certificates of completion are available at the registration desk, which now isn't open today, but any of the staff members can help you get the certificate. Our faculty has disclosed no financial conflict of interest, and a copy of the disclosure sheet is available on the table outside the room. Also, you'll need to sign in. There's a sign-in sheet on that table in the back and also out front, so be sure to sign in if you want the continuing education credit. So now, turning to the good part of the session, I'd like to introduce our presenters today. Amy Allen is Department Manager, Correctional Health Services Unit at the Kenosha County Detention Center, Kenosha, Wisconsin. Amy began her employment as a correctional nurse with the Kenosha VNA in 2006, providing care to patients at the Kenosha County Jail and the Kenosha County Detention Center. Prior to working for KVNA, she was employed at Wheaton Franciscan Healthcare as an oncology hematology floor nurse. She received her associate degree in nursing from Gateway Technical College in 2005 and is currently working towards her BSN. So we're so glad you can join us. We also have Michael Puskarich, who's CEO of the Kenosha VNA. As a senior level executive with 25 years of experience in healthcare, he has the practical knowledge needed for guiding healthcare organizations to be successful, including physician practices, integrated delivery systems, behavioral health, accountable care, and home health care organizations. Michael is committed to providing the best possible skills service to patients and the betterment of the home care industry. His strategic thinking and emphasis on accountability for success are qualities that will benefit both the agencies he leads and the VNAA. We're so glad you both could be here for this really interesting and innovative session, and I will turn it over to you now.
Thank you. Good morning, everybody. Glad you could join us today. We have an interesting presentation to put on for you guys. I've been in home care for quite a while. Led a lot of different organizations, as you can tell, but primarily my experience has been within home health agencies and home care. And until I got to KVNA, this type of a service and this type of a program wasn't something that was even ever on my radar screen. But now, after being exposed to them for a year now, feel that I think it's something that, as we look forward into our own agencies and we look forward in our communities, I think this is an opportunity. We all sit around and we think about, how we continue to look at revenue streams and look at different ways for us to do things. So over the years, we've looked at immunizations, we've looked at other services within Medicare, we've looked at managed care services, we looked at commercial services all around what we do. This is something, too, that I think you guys can go back to your communities and look at. There's some laws on the books that we'll talk about, but also, too, look into your communities, because not every state and not every locality can allow you to do this. So take some time, look into your local regulations and your local state laws, because they may allow an agency. Wisconsin allows an agency to be able to do this stuff, and some states don't. But maybe there's some lobbying efforts and some things that can be done to make that happen. But it's basically an extension of what we do. We see people in a home. And in this case, for correctional health, their home just happens to be a jail. So I'll go forward now with it. This is our disclosure statement. Learning objectives is to help understand the history of our relationship with Kenosha County Sheriff's Office, to guide you in a pursuit of different revenue sources, outline the differences in providing care in a correctional setting, and to help agencies understand the benefits of correctional health program. In 1976, there was a landmark case called Estelle V Gamble. And what that did is that set the precedent for mandating care to correctional health patients and inmates. And so what happened in that case was a gentleman, Mr. Gamble, had hurt his back. And so he was on a work release program, had gone through a number of different renditions through the system. And so they kept bouncing him around from physician to physician, nurses looking at it. And he also had some congestive heart failure issues and high blood pressure. And so went through that, and it took him a number of months to figure out some stuff. He had a couple of stays in the hospital, and so he sued because he said that the lack of medical attention that he got was cruel and unusual punishment. And so went up to the Supreme Court, they looked at it, and basically what ended up happening was that they said that it doesn't rise to the level, if it was in a normal community, to how he was treated, because they didn't take some x-rays of his back, they didn't do some of the common things you find within the service delivery, what we do on a standard basis. And so what they found out was that it could rise to the level of malpractice. It didn't, but they felt that it was necessary to deliver a community standard of care for inmates. And so as we look at this, what's interesting is that inmates in prison are the only people in the United States that are constitutionally mandated to have health care. It's kind of an interesting concept. It's also a concept that when they come into the door, we can't refuse treatment to them. We have no clue what kind of care they've gotten on the outside. We don't know what kind of diseases they have. And so they come in with a litany of things. And so it says an inmate's Eighth Amendment rights are violated when an inmate is denied or unreasonably delayed access to a physician or diagnosis or treatment, failure to administer treatment prescribed by a physician, and the denial of professional medical judgment. And so if you don't do those things and you're a county that operates a jail, it opens you up to some significant liabilities. And so it's just kind of interesting that as we look at healthcare reform, and that's why I brought that up, that these are the only folks that are mandated to have healthcare. It's widely accepted that you provide them with a community standard of care, and what that means is provide the patient with what is medically necessary as opposed to what they want. And so if they want to have a designer medication or some sort of an upgrade to whatever they're looking at, you have the discretion to use a generic. You can use the lowest level of services in order to provide the care necessary to get them. There's no mandate, there's no payer for this. What it is you're trying to supply a base level of care to them. You're also to provide the patient with care comparable to what a government program such as Medicaid or Medicare would receive. And so you have to deliver care, you have to deliver it compassionately, you have to deliver it based upon what they do, but there's no mandate that says you've got to supply them with XYZ level of medications. You've got to do certain things like that. There's just, it's just you have to give the base level of care. State court is mandated to provide all medically necessary treatment in a timely manner. So you've got to do it timely. You can't kick it down the street. You can't wait months in order to take care of the patient. The patient comes to you with back pain or they feel they just had a heart attack, you must act in a reasonably timely manner. And controlling care costs can be a problem for counties, given the recent spat of large adjustments for inmate mistreatment. What happens is, what's unique about this program is who provides this care are what we'll say large national corporations. And they're driven from a physician perspective. And so what they do is they go around and they bid on these things. And the counties want to do the lowest cost possible. So folks will way underbid on the products. They'll get the contracts. And then because of the constraints of the contract, because of what they bid on the contract out, they're refusing to lose money. So they'll restrict staffing. And so there was recently a case at Rikers Island where an inmate passed and it went to court, family sued, and the family got a $30 million judgment. In our area, we have Milwaukee, which is a little north of us. We also have an area called Racine that's a little north of us too. Milwaukee County Jail has recently had 2 lawsuits for 2 deaths in their jail system, and Racine recently had 1. We've been doing this, you'll see, quite a while. We've not had any hints of lawsuits, and so that's a marketing component that when you go to sell this to your counties, that if they've had a judgment or they suspect that there's a possibility for a judgment, that's the way that you can come in to justify your services. It's not only cost, it's also the avoidance of potential lawsuits. How we started in this, in 1980, we got a call from the Sheriff's Department. We've been in a community for 90 years. We started in 1927, and so we've had a good reputation in the community. We've done a lot of things like that. So because of that reputation, the way we took care of the community, they called us and said, hey, we have no inside medical staff, but we happen to have this quadriplegic inmate that has a catheter, and we don't know what to do. So we came in, we did those services, and then we started to provide intermittent services. So then we went from this one patient, and then we started educating the guards on how to recognize different medical conditions. Then we provided some short assistance, which we had an on-call nurse, and then we provided what's called sick call, which once a day, what we'll do, and Amy will talk a little bit more about that, but we give them a time where if they have illnesses or they have something going on, they can physically see a nurse and a physician if necessary. In 1987, the relationship expanded into a formal agreement where we then went for 20 hours of service per week for a nurse at a minimum. If they needed more, we would provide more. So you kind of see it's been a kind of incremental kind of thing. Services began to expand in 1992. The jail census began to increase, and so we increased from 20 hours a week as a minimum to 40 hours, and then we started doing on-call 24 hours a day. So anytime they needed care over a daily period, we would provide that care. In 2000, they expanded their facilities and opened a new facility, and so now they need a nurse 24 hours a day, 7 days a week. So they looked upon us to do that. And so we also provided a nurse for 16 hours a day on Monday through Friday and 8 hours on the weekend, so we were staffing it all the time. So they have 2 facilities. They have what they call pre-jail facility, which is called Kenosha County Jail, and now the second facility is called Kenosha County Detention Center. So the jail is kind of a pre-facility before somebody goes to court, but it's the main intake facility for all the inmates, and that's where the questions and things like that are asked. In 2007, they recognized the need for mental health services. So the sheriff's office asked us to employ a licensed clinical psychologist for 20 hours a week. So we've gone from a little bit of taking care of a catheter patient to some on-call and some hours, some education, to constant nursing, to now 2 facilities, to now mental health services. In 2015, we evolved even more. Now we handle all of the services related to it. They would have a separate contract for the physician. They would have a separate contract for the dentist. They would have a separate contract for nursing. They had a separate contract for psych. And all these things were broken up into separate contracts. As of 2015, we talked to them and said, you know what, we can provide all these services, so we're going to include the physician, we're going to include nursing, we're going to do psych, we're going to do social work, and we're going to maintain your medical records. So we bundled that all into one contract. Then this year, we added dental services into the agreement. So they've gone from maybe 5 providers, would you say? Is that correct, Amy? About 5? So they've gone from 5 providers and 5 different contracts to basically 2. We have 2 now. One for the mental health services and one for everything else. So we've consolidated it. They now have one relationship where they used to have multiples. So it's been a win-win for the county. Also along that history is when you have a relationship for that long, sometimes they don't appreciate your relationship. And so there's been times they've gone out and they've bid for services. So we also do the pharmacy. I don't think I mentioned that, but we also supply the drugs and all the stuff like that. And so we have a contract for a pharmacy. We then have the physician prescribe them. We then do them on our 6th call and running through as Amy begins to describe what the nursing staff does. But during renditions of this, there were times when the county went out and bid or asked for RFPs and stuff like that. The last time they went out and asked for RFPs, we said we weren't going to do it because they're always kind of asking us to always reduce our prices. It's a typical relationship with a government entity. And so what we did is we said, we're not going to bid. We're not going to be even involved. So they went out to the market and they got all these bids and they did all this stuff. And guess what? They picked up the phone and they called us. And they said, you're the lowest cost that we have nobody else that gave us an RFP that can do it at your level of cost. Will you please come back? So what we said is, we said, okay, and we'll talk a little bit more about that, but our contract is based upon our costs, including overhead, plus a margin. So we build a 5% into there for us to have a 5% margin because we feel that's reasonable, giving everything. And so that's kind of how we got to that piece of things. So that's kind of the history. Now I'm going to turn stuff over to Amy, and Amy will talk about kind of our structure and the nursing stuff, and then I'll finish things up.
Do you want to wait for questions till the end?
Yeah, can we wait until the end? Do you mind?
Of course, not on my call.
All right, so today we currently employ a director of correctional health. We have 2 full-time department managers for each facility. And like he said, we have 2 nurses 24/7, 365 days around the clock at both the Kenosha County Jail and, just the Kenosha County Jail, and then 1 nurse around the clock at the Kenosha County Detention Center. And like he said, the Kenosha County Jail is the intake facility, so we always have the 2 nurses because everybody's coming in from off the street. We have people that come in on drugs or alcohol, and they're going to be going through withdrawals, so they need to be evaluated pretty quickly so we can get them treated. And then we have a physician. He comes into the facility once a week. He provides 2 hours at each facility, and he's on call 7 days a week around the clock. We also have a nurse practitioner. She's on site for 40 hours at both facilities. She splits up her time, and she's available for orders from the nurses. And her average is 109 patients a month between both facilities. And then we also have our mental health team. Like he said, it started out small with 20 hours a week, and now we have an average of, 110 hours a week. As you know, the jails have become the mental health facilities across the country, so we're getting a lot of more mental health patients. So our team consists of a licensed clinical psychologist, a licensed clinical social worker, a licensed practical counselor, and then a master's in social work. Our dentist is on site 2 hours, and he only goes to the 1 facility, and then we just transfer any patients over from our detention center to the jail when they need to be seen. And he sees an average of 13 patients a month. We have the 2 administrative assistants at each facility, and they help with the clerical things and filing. The average population for the Kenosha County Jail is 220. That was in 2016. And in KCDC, it was 536 last year. Some of our goals: we need to provide the most advanced, cost-effective healthcare services available in the current market. So some of the ways we do this: we work with the pharmacy to create a formulary to ensure we are using cost-effective drugs. And then this also helps so when the patients are released, they are able to afford the medications. A lot of the times these people come in and they haven't had access to healthcare, so we're the ones that are diagnosing them with diabetes or hypertension and things like that. And then also, like he said, you provide what's medically necessary versus what the patient wants. Sometimes we'll have patients come in who have had hernias for years, and all of a sudden they say they need it repaired. Well, we take a look at them, the doctor evaluates them, and they need to determine what's medically necessary. And most times it's not. And then we also want to deliver care in a manner that emphasizes dignity, respect, and professional courtesy to the individuals being served in the correctional setting. So staff is trained to be professional, firm, fair, and consistent. So when working with these larger populations, you want to make sure that you're not giving anything unnecessary, because what you give to one person, you're going to have 500 other people wanting that same thing. So whether it's the extra blanket, the extra mattress, and things like that. Some of the services we provide, the medical services, all clinically necessary medical services provided on site as effectively and efficiently as possible. We do psychological services. They do evaluations, assessments, psychotherapy, substance abuse counseling, crisis intervention, and de-escalation. Management counseling, strategic planning for program development, on-site education, so on-site training for ongoing development of medical, custody, and ancillary staff, and policy development. We draft policies and procedures consistent with the program structure, and we also have to make sure that our medical policies are matching some of the jail policies for things like hunger strikes. You need to know like when medical staff gets involved and when you need to call the doctor and things like that. Professional staffing, continuous recruitment to assure licensed caregivers are the highest quality. And accreditation, experienced in accreditation, preparation and support from the National Commission on Correctional Health Care. And then quality assurance. We do clinical audits and case reviews are conducted to ensure compliance with accrediting payer guidelines and standards. So.
Sorry about that. So you begin to see it's very complex. I'm going to go back a little bit just to kind of go over some things here. You see, it's a pretty, it has a lot of components to it. Right now, this operation within our service area is about 50% of our total revenue for the year. So it's a sizable portion of of the services we offer as an organization. Our census in home care is about 120-ish, so we're not a large agency, but you can kind of see how this kind of helps kind of level us out a little bit, because we have a large portion of our business that is pretty consistent, has a long-term relationship with it. Additionally, we have 9 RNs at one jail. We have 5 RNs at another jail. So we have 14 RNs in addition to the RNs that we currently have within our service, within our home care services. So we have 8 RNs in home care. We have actually more nursing services in this area than we have within our home health area. We have some part-time folks. We have administrative folks. We're able to use LPNs. So there's a number of different things that you can do in this that from a regulatory perspective that we are bound with within a home health agency, we aren't bound with within this demographic. One of the important things is mental services. What we've consistently found out is that mental health today is done primarily through the prison system. So homelessness, just general things around psychosocial problems all end up here. Our formularies that we got to work on and the things we got to do is we've got to always be looking at our psych formularies, our psych medications. Additionally, we get a lot of patients that come in pregnant. So you got child care and pregnancy care. We also get patients at times, I don't know how many we got now, but we get a lot of AIDS patients. And we all know that AIDS patients they're all on some formulary of a medication, and everyone's different. And so we try to maintain that. We also get a large population of ICE patients. And so we have a large group of patients that come in that are from ICE services and customs and immigration. And so we have to deal with that population. So we have a wide gamut of illnesses to deal with. We deal with chronic conditions. We deal with complex medical conditions. We deal with psych conditions. There's a lot of things that we have to deal with in this setting. So it's a very complex clinical operation that if you asked me a year and a half ago, I wouldn't have a clue of what that is. But you would agree too that this has been, you've spent a lot of years in in that area and would agree that it's a very complex clinical practice because you're dealing with all of this stuff. But it helps us because it's also an extension of what we do within our community. So it's another community add-on service that we do, that when we do have other programs like immunization or we go to the community, we talk about our services, it gives us another tie-in to the community of the way we benefit our community. And so it's very good. Every time I talk to business leaders, they're surprised we perform these services. But it further helps them to understand the complexity of the things that we deliver. So when we first started doing this program, as you see, it was very incremental. But in 2000, it started to be a significant number. As you notice from our timeline, it's when we started doing some kind of holistic things and started taking care of it. But it was $420,000 a year in 2000. Right now, it's in 2015, $202.2 million. Very sizable growth rate. If you look at that growth rate, we would all love to have our Medicare revenue grown at that kind of a rate, wouldn't we? Over the last 10 years, most of us have seen a curve on Medicare that goes like this on a basis, or it's been somewhat flat across the board. So you can see an annual growth rate of revenue of 12%. So part of it is the size of what's coming through the Kenosha jail system. Part of it is our extension of services and all the stuff that we offer. The reference that we have for this is Estelle V Gamble. So you begin to see that that's the Supreme Court case that set all this stuff up. There's been subsequent cases that have come out, but that's the main case. If you really look at this, this has been like for our 2015, I think our 2016 year, we were maybe 2.4 million. So you begin to see that services continue to escalate. From the documentation side, unfortunately, we rely on the county for that stuff because it's the county's business. We're a contractor for the county. So we don't have an electronic medical record. We've been working with the county for a number of years for them to establish an electronic medical record. Right now it's paper. So the county has threatened a few times the last couple of years to do that, to go towards an electronic medical record. They're committed to do that. But again, all budgets in all communities are somewhat taxed, so you gotta sometimes take the good with the bad. So we're all in constant contact with it. But it also gives us a forum for us to meet with, the county executives and the county leaders to continue to promote our agency because of these types of things that we're able to do. So it helps us quite a bit in our local community. But it really does create a very stable revenue stream for us that's very much less, it's complex from the patient perspective, but from the regulatory perspective, it's night and day to what we have within the home health arena. You're not doing OASIS documentation. You're not worried about fraud and abuse. You're not worried about referral sources. You're not worried about out there beating the payment, beating the referral sources to try to see how we can grow our revenue, meeting with patients and convincing them that home care is good for them. You have somewhat of a captive audience. So it's been a very good program to be exposed to. And so it takes some time. So what I would suggest, if anybody thinks they want to do this, we're more than willing to have conversations with anyone outside of this. We'll help out in any way that we can. But I would suggest that maybe you don't take a 30-year path to do some of this stuff. But think about going in a toe at a time, going in slowly into this pool, so you can understand the complexities of your local community, maybe a little different than our local community. But I would suggest that looking into this, making sure that you can do those services based upon your state laws. And if you can, take some time, work into the program, understand it, talk to your county leaders, find out how happy they are with their current provider, how unhappy they are, why they're unhappy, why they're happy. And from that, maybe they're unhappy because their staffing on their nursing side is bad. And so you can say, hey, you want me to come in and supplementally staff your folks, or do you want me to take over all your nursing part of it? And things like that. And there's various ways you can do this too, because counties a lot of times own these programs, so they have all the employees. And so if you do gain some equity on it, you can go in and be a contract provider and just help manage the organization from a clinical and a healthcare perspective. So there's a litany of things to do within this arena that you can do. And so Those are all things that I think are on the plate as you look at this. It's a very diverse kind of thing, and you can pick and choose kind of what you do and what you don't do. So I think now's a good time for questions. Anybody got questions?
I have a couple questions. First
Okay.
of all, do you provide hospice to these inmates?
No, we do not provide hospice. We have a local hospice provider that we work with. Am I correct on that? You want to
Yeah,
talk a little bit about that?
And in those situations, they would end up going to a nursing home because they wouldn't be able to care for themselves. So in order to be in jail, they need to be self-caring, so.
And then, when they went out they did the RFP and you bowed out. I'm just curious, when they came back to you, do you have quality measures in place? Was that part of the evaluation process with the county? Or was it all cost?
No, it was all cost. I think what it was quality's part of it, but there isn't what you would call quality measures. What there is the county knew we did a good job. The county knew that the inmates were well taken care of. The county kind of knew that. That was a kind of an underlying thing of it. We didn't have data that said, look, our quality and how we take care of inmates is X, and it's X higher than this other provider over here. We didn't have anything like that. What we had was a relationship long-term with the county that we had dialogue with them. So if we had issues, we worked on it. And so we had a very close partnership and relationship with them. And so when they got these other bids, they began to realize so they knew our quality. They were nervous about going to somebody else. Additionally, they didn't want to pay more money because they're all under budget constraints. And so when you go to a county meeting, we're typical in our community over everyone, the sheriff might be set to talk for 20 minutes about his budget. And what ends up happening is the county commissioners talk about, for 45 minutes, about what lawnmower they're gonna purchase for the county to cut some golf course or cut some picnic area to promote tourism. And so some of these things get tabled to the background, and so some of it has to be what we'll say, I'll call it backdoor diplomacy, where you set meetings up with people and you talk to them one-on-one with the county executives, and to build that rapport and to build that relationship. And so through the years, they knew we were quality. There's been some really bad press out there. 60 Minutes has done reports, 48 Hours has done reports. Most of the major media have done reports on mistreatment of inmates in jails and prisons. And so there is a opportunity, I think, for ethical, morally guided providers like us to be able to do things like these kinds of programs that are an extension of what we do, but also build off of our quality reputation within the community of delivering compassionate care, rather than being a for-profit that's here to enrich shareholders or enrich a bottom line for somebody that has 50 jails that they manage.
And then you may have said this in the beginning, I think that I was late.
No problem.
Is the county able to bill Medicare or Medicaid?
No.
Any of this?
No, it depends upon states. Now, there are some initiatives, because what happens when an inmate comes into the jail services, if they're on Medicaid, their Medicaid's revoked. And it depends upon each individual state. And so what that does is that falls onto the county to make that happen. I don't know if it's a significant dollar for the state of Wisconsin or not from a care perspective, because you're looking at maybe you have 5,000 inmates throughout the state. I'll just make up a number, even maybe it's 10,000, I don't know. But would that really, what percentage of it's Medicaid, and how would those dollars impact the state? I don't know, but they're revoked on their Medicaid when they come in. So you can't really bill Medicaid. There are some bills that are making it up to the state that are looking at trying to get that reimbursement back to the counties from a Medicaid perspective. But that's still in the works, but it would depend upon each individual state. But Medicare doesn't cover either. So.
We usually try to just recruit registered nurses, RNs, so that they can do the assessments, because we're doing a lot of assessments. And then they go through a 2-day orientation training period at the KVNA office. And they watch videos, go through PowerPoints with the director. And so that's not always. No, it's nice to have, but sometimes we have taken brand new nurses and they do well. So
It's,
do you know the retention rate?
I know for the corporation overall is pretty low, but I think our highest area is that area. We were just talking about how we have a few vacancies that we're trying to fill. What typically happens is you'll do an interview with someone, and you'll explain to them the program, and they're like, "Oh, okay, this sounds interesting." And then you do an orientation time period, just like we do in home health, and they realize what's necessary for it, and they realize who they're dealing with, and they get sometimes scared away. And so sometimes that happens right away, sometimes it happens a little bit, but it's an orientation cycle. How long is your orientation cycle whenever they come in, once they get hired?
The 2 days at the KVNA, and then they're usually on orientation for 90 days, or training for 90 days.
Yeah, so they're on training for about 90 days. And so before we'll put them, let's just say we have a night shift. We've just added a third shift on one of our locations. So before we did that, we would orient them, have them 90 days on the day shift, and then we would turn them over to the night shift to be by themselves. So there is a bit of a orientation cycle so they can get used to the routine, used to dealing with the inmates, used to dealing with some of the stuff that they won't find out in the normal healthcare arena and delivering care. But there is the availability. I mean, you would like to have folks with prior correctional experience. It's not a requirement, but at least you know that there's a better success rate if they've done it before. And you know, we don't want to hire all nurse ratchets. So you want somebody that does have some compassion in what they deliver. And it can at times be a high stress environment because you got, as census increased, the demands on the nursing increases. As your population gets sicker, the demands on the nurses increase. So it's not a simple thing. It's not like you're in Gunsmoke and have just a drunk tank for the local town drunk for that day, and it's not sleepy like something like that. But it's complex, and so it just depends upon who comes in with what conditions. You know, there was a time, I think, last couple months, we had 3 HIV patients on service. We had 2 opiate-addicted pregnant ladies. And so you find things like that. You find folks with undiagnosed mental conditions. You find chronic conditions. So from a practice perspective, we don't deal with a lot of that in our current home health arena. So you just need a different, I guess you need a few different tools in your tool chest to deal with an organization like this over what we would in home health.
What's the average stay of a correctional inmate?
It can be anywhere from 24 hours to a year until they get sentenced or released, depending on their charge. But we've had patients there up to 3 or 4 years because they were fighting their cases and that. So it takes longer. So it varies.
And in the prison system, the county jails are the places that they go as they await trial in the local area to then be, if they're convicted of a crime, then they will go to a state penitentiary. And so it's more or less a holding area for either misdemeanors, small criminal offenses, and those awaiting trial for larger offenses that will then translate into going to a state penitentiary. Uh-huh. That was in 1980. I don't know. I don't know what was done. I don't know how that precipitated, but maybe, who knows? Maybe he was publicly intoxicated. I don't know. But that's what kind of kicked it off. It's kind of interesting. It does lead some litany of questions, but it was just kind of a unique circumstances that let us get our foot in the door. And then through that, it then morphed into all this that we see today. Now we've gotten to the point to where we have another good thing is we have our director of clinical services and our 2 department managers are all accredited. What's the accreditation you guys got?
The NCCHC, National Commission on Correctional Healthcare.
And so that's very beneficial because there's not a lot of operations that have that kind of accreditation out there. We're also looking at getting our services at our 2 locations accredited by the same accreditation body. What that does now is once we've kind of gotten that all kind of straightened up, that gives us a little, it's almost like a certificate or a surveyor within the home health arena, whether it be JCO or ACHC, whatever it is. Once you get that accreditation, it kind of ups the game a little bit, and it's the same way for the correctional things. We're also debating about how we grow this business. We're looking at other counties within our arena and saying, you know, what's our strategy? I already mentioned to you that Milwaukee has a couple of lawsuits outstanding. Racine, which is another neighboring county, we cover that county as a home health agency, has some issues. And what do? Do you go to a sleepy other county jail and kind of test and make sure you can do these kinds of things? They have a for-profit that comes in and does that. And so it would probably behoove you to kind of, if you want to look at things like that, you might want to Google who are providers of that, and you can see their websites and what all they do. But there's a number of for-profit companies out there that do those things. So, yes, ma'am.
On your pharmacy costs, are those passed through or are they capitated? So like if you've had to pay for expensive C drugs or HIV drugs, like do you take the hit?
Yes, we take the hit. So we negotiate a contract based upon our budget, and so we do our best estimates on stuff. So we're basically capitated on it. If we can do it for cheaper, we make a little bit more money. If it costs us a little bit more because medications are higher and we have more complex patients come in, we eat those costs. So we're somewhat at risk. The risk is mitigated. And we can go back to the county and we can say, hey, we've had some cost overruns, what can we do? Because the county does get paid for their ICE patients. They get a certain dollar amount per day for every ICE patient that they have on service. But that goes directly to the county, and the sheriff's department doesn't come to us. And so there's an ability to continue to have dialogue with them, to talk to them about how we can get additional reimbursement from them for any of our overages and stuff like that. So we've never had a year where we've been so far under as far as cost goes. We want to provide a certain level of service, so our budget's built that way. So, yes, ma'am.
But would you test patients for hepatitis C? Is that course of treatment is $150,000 for you in 90 days?
I would say based upon this budget, unless it was something that was truly noticed and truly there, we would probably shy away from that. It would have to be clinically mandated for us to do that in order for us to take on that. Because for us to eat $150,000 worth of a treatment would put our program in dire peril. So we just don't have the wiggle room to do stuff like that.
You mentioned several patients coming in with opioids. What's your process for getting them treatment?
Currently, we're collaborating with the Kenosha Health Department, and there's a program that we've started for people coming in, and if they're getting released back into the community, they're offering the injections, the naltrexone, and so anybody who's interested in that can work with the county health department and go through their testing. They come into our facility once a week and evaluate these people, do the necessary blood work, so we're not actually involved in it, but they just come in and help out those people, and then once they're released, they'll pick them up from the facility, give them their first injection, and provide them with all kinds of counseling and the needs to help them stay clean. So, yeah, currently.
It's an epidemic. We find more and more that folks come in, but there's something you guys got to realize too, is that as bad as an opiate withdrawal is, there's a high livability rate with that. The part that people don't all realize is that alcohol withdrawal can kill you. Opiate withdrawal won't kill you. It will be difficult, but there is a higher propensity to have an alcoholic in our midst and come in pretty drunk, and the medical acuity of that patient will be much higher than the opiate. So a lot of folks don't realize that alcohol withdrawal can be rather adverse when it comes to medical outcomes. So,
So within your program, you do a detox, but you don't do the treatment?
Correct.
correct. Because it's not mandated to do the treatment. But when we discharge them, we make sure they do get some county services and some supportive services from that perspective. We're also working with the county sheriff's department to look at how we discharge the patients and how we look into the community for supportive services for the inmates when they come out. So we're always looking at trying to find better ways to benefit. And if we could do some things from that perspective and get them set up, maybe we can be part of the solution towards bending that epidemic, especially around the various drugs and things like that. It's interesting to be in a corridor between Chicago and Milwaukee. And so you do see some things in that corridor that are bad. So, it's not we don't live in a heavily violent area of the thing, but there is a bit of a gang population. There is a bit of a drug trade up and down through that area. So we do get a good bit of gang stuff, not as much as other counties. The county has done a very good job of making sure in the 80s that they were very up on the gang populations that were coming from Chicago up. They've more settled into the Racine area and the Milwaukee area and not really in the Kenosha area. But we still have our fair share.
Is security for your staff an issue, or does it affect your insurance premiums or anything when you're doing services like that?
No, because usually whenever we do have a inmate, they're escorted by a detentions officer, and so there is constant supervision over them. When we're doing a physical, you want to talk a little bit about that?
Yes, so basically there's always an officer with us anytime we have contact with any of the inmates. And then we do carry radios on us that have body alarms, so if something happens, we'll have probably like 10 officers or whoever's available come running to the area. So there's never been an issue for the nurses. So the inmates are usually pretty respectable, so they want to see us.
It's very similar to the home health folks. When we go into a bad neighborhood and the community knows we're there to treat the community, usually the elements that are less savory than others usually welcome that because as unsavory as they are, they care about their community and they care about, because you could be treating their grandparents. And so this situation is very similar. So you're there to help them with one of their medical conditions, so they're going to be less adverse to resist you and to be against you. We do get grievances. We definitely do get grievances. As I think about some of our statistics, I think we do about, in a year period of time, we probably have in the upwards of 18 to 20,000 encounters over a year period of time with a nursing staff member. Physician encounters, or we're trying to get those only in there, so that's probably about, about 10, 15 a month around the physician.
That sounds about right.
And then we try to also help the county by managing what goes out into another facility. So if they need to go to an ER visit, we can help out by limiting the number of times they go to an ER, limiting the number of times they can go to another outside service provider, because the county has to pay for that, and that doesn't come out of our budget, that comes out of the county's budget. So we have a number of ways we can. The hard part is trying to convince a county you're saving them money when they're not writing a check. And so that becomes the interesting conversation as you're selling the services to the county, is unless they've had an adverse event lately and they know the pain of writing that check and of funding that, because a lot of times they're self-funded from their liability insurance perspective, so they're writing that check directly out of county monies. So after they've done that lately, they understand that pain. But if you're a provider like us that's kept them 30, almost 40 years from getting into that position, although you've done that, that's a great thing, they don't understand your value because there's not a dollar amount attached to it. So when you do go to them and ask them for more money, you're asking them to take money away from another area that they've spent money, and so it becomes somewhat of a hard sell. But again, we've got to do the right thing for the patients, and so our goal is to even for an inmate, is to treat them with respect and dignity. And so that goes a long way. But it is a busy operation. Is there, I guess, in an 8-hour day, you have a lot of time to sit around and twiddle your thumbs?
No, not at all.
It's pretty regimented. There's a limited area. So when you deal with medical records and stuff like that, medications are all locked down. They're all on pill cards. You've got to deliver them twice a day. Is that correct?
Yeah, mostly twice a day.
Twice a
there are
day.
a few, like 3 times a day, but we try to stick to twice.
So you're running around with a medical card. You've got to go through, hit all of them. I mean, so, it does become, somewhat of a time, so you try to figure if you're trying to do that in 8 hours, or what's our normal shift hours?
12 hours.
Yes.
So 6 a.m. to 6 p.m. or 6 p.m. to 6 a.m.
So those are our staffing hours. So we do 12-hour shifts, 4 days a week, or does a nurse really schedule 3 or 4?
7 days a week.
But I mean, what do you typically schedule a nurse for as far as 12-hour shifts?
Oh, 3 12-hour shifts. And if we need to, we can schedule them an additional 4 somewhere.
Yeah. And also, too, when we do have areas or times when we have less staffing, we've been successful at letting them do overtime and things like that to help fill the needs. Now, those overtime hours are not in the budget. But the staff member that probably is vacant is in the budget, so it's still economic for us to do those kinds of things. So we're still trying to, it's a capitated thing, so we get, and it's nice because they send us 1 check a month and it's very automatic. And so it's nice that, boom, beginning of the month, you're going to get your check from the county. And that's going to supply you through the month. So the hard part is managing the pharmacy costs, getting the formulary in, making sure you got a good formulary, making sure you got a good formulary on your psych meds, making sure your medical director is comfortable with the psych meds. Yes, ma'am.
What you're getting on that reward is based on the number of staff and your cost plus not the number of inmates that you carry.
No, it's a cost program. It's I guess you could, but then you'd have to flex your staffing up and down. And if you want to try to recruit and retain staff, we know how hard that is in home health to do that. Now you got a difficult practice arena in a correctional facility, and now you're flexing staff up and down based upon inmates and stuff like that, and you just can't. And what you would do is, if their population tanked, probably the county would come to you and say, my population tanked, we need to renegotiate your contract. So there's a clause in the contract that allows us to sit back at the table again and renegotiate if there's any material change in it. So if the census goes way up, we can go back to them and say, hey, your census just went up. We're having difficulty with 14 nurses covering that. We need 21 now, and here's why we need 21, and this is what we're going to do with these extra costs. Will you will you amend the contract for this? So we've also dabbled with the idea of actually fronting the money to the county for the EMR. But I'm anti that, because once you do that, I don't have a leverage point anymore for pushing them to fund it. And so there's not a way within our mechanism. Plus, it's their product, it's not ours. If we did that, it would be ours, and when we left, we would take that with us. And so it really needs to be the county's responsibility.
Are the rest of your nurses on an EMR and your other side of the business?
Yes, we're all on EMR on the other side of the business. So, but they're all paper. So, and then they just put a new system into the jail around their intake system, and so their inmate numbers are going to change, and so our files have to be redone, and that's so there's administrative things, there's stuff you've got to do. There's storage constraints because you have nobody builds a jail, so you can have unlimited file storage in there. You know what I mean? I mean, we're kind of shoeholed in some areas that were built. When was that pre-trial? When was do you know when the jail was built?
Not the jail, no.
It was probably in the 80s, wasn't it?
I have no idea.
I'd probably say late 70s, early 80s, they built the jail, which is the intake facility. In 2000, they built the county detention center. But even there, they don't have even the one built in 2000 doesn't have a good kind of layout for the clinicians, does it?
Yeah, not really.
Yeah, because that's your main facility, right?
Right.
Okay. So even then, something built in 2000, not that long ago, doesn't really kind of fit for us to be able to efficiently do healthcare services, because when you're designing a jail, you're not thinking about how to deliver medical care. You're thinking about how to efficiently house and supervise inmates. So it's somewhat of an afterthought. So, any other questions? Well, thank you very much.